Bismillahirrahmanirrahim. Today we are starting to discuss the disorders of the thyroid gland and thyroid hormones. But before we discuss diseases of the thyroid gland and disorders associated with thyroid hormones, first we make a brief review and introduction to the thyroid gland and thyroid hormones. The thyroid gland is a very important gland, and the thyroid hormones are very important because these hormones accelerate the basal metabolic rate of the body. And we know that how much metabolism is important for the body to generate energy. The thyroid gland is a butterfly shaped gland which is anatomically located below the larynx, interior to and on each side of the trachea. The thyroid gland has left and right lobes connected together by the narrow isthmus, and the thyroid gland is composed of a large number of thyroid follicles. The follicles are separated by small amount of connective tissue, and these follicles are lined by the follicular cells, which are cuboidal epithelial cells. The cells are arranged in a follicle that they enclose a central lumen which contains the colloid. And the colloid is actually the thyroglobulin protein, which is a glycoprotein secreted by the follicular cells into the lumen of the follicle. Now, the thyroid gland forms thyroid hormones. The two major hormones are the thyroxine or tetraiodothyronine and triiodothyronine or T3. Now, for the synthesis of thyroid hormones, the thyroid gland needs iodine. Mostly, the iodine is in the iodide form, in its ionic form. And in its ionic form or iodide ion, it is taken up by the follicular cell. But before the iodine can be incorporated into the thyroid hormones, it must first be oxidized to elemental iodine, the atomic form of the iodine. And this oxidation is brought about by the enzyme thyroid peroxidase. In the iodine or elemental form or in the atomic form, the iodide that was taken up from the blood by the follicular cell is secreted into the lumen of the follicle. Now, the thyroglobulin, which is a glycoprotein and is secreted by the follicular cells, contains the amino acid tyrosine. And the iodine in its atomic form will bind to the tyrosine to form the thyroid hormones. And this is called iodination of the tyrosine. Now, if the tyrosine amino acid binds one iodine, the resulting molecule will be monoiodotyrosine. If it binds two iodine atoms, the resulting molecule will be diiodotyrosine. So initially, the monoiodotyrosine and diiodotyrosines are formed, and the thyroid hormones basically are the iodinated tyrosines. Now next, the one monoiodotyrosine and diiodotyrosine couple together to form the T3 triiodothyronine, and 2-DIT diiodotyrosine coupled together to form the tetraiodothyronine, that is the thyroxine. So the major forms of the thyroid hormones are the T3 and T4, and these hormones are formed in the lumen of the thyroid follicle. Now the follicular cells take small pieces of the thyroglobulin that contains the thyroid hormone by pinocytosis. And as these small pieces of thyroglobulins enter into the follicular cells from the follicular lumen, the lysosomes contained in the cytoplasm of the follicular cells unite with this colloid droplet, and the lysosomal enzymes and proteases then break down this colloid droplet of thyroglobulin and cause the release of thyroid hormones. This breakdown of the colloid droplet also results in diiodotyrosine and monoiodotyrosine. And since they are of no use as thyroid hormones to the body, most of them they are acted upon by other enzymes known as the deiodinases, which remove the iodine from mono and diiodotyrosine, and tyrosine is released, and this released iodine is recycled, used again for the formation of the thyroid hormones. So the iodine that was taken up by the thyroid follicular cells, thyroid hormones were formed, iodination and coupling occurred in the follicle, in the lumen of the follicle containing the colloid, and the colloid drop was taken up by the gland through pinocytosis, and with the help of proteases it caused detachment of the thyroid hormones, and they are then secreted into the blood from the basal surface of the follicular cells. Now the thyroid hormones which are formed by the thyroid gland, and the whole process of the formation of thyroid hormones started with iodide pump, in which the iodine is taken up by the follicular cells and can cause high concentration of the iodide and iodine in the follicular cells. As the follicular cells cause synthesis of the thyroglobulin, which is secreted and exists as colloid in the lumen of the thyroid follicles, the next step is the oxidation of the iodide ion to iodine by the thyroid peroxidase enzyme. Next to this is the combination of iodine with tyrosine to form iodinated tyrosines, and then the release of thyroid hormones from the colloid droplet and secretion of the two thyroid hormones, the thyroxine T4 and T3. Now, the thyroid gland forms these hormones under the control of the anterior pituitary gland, which secretes thyroid stimulating hormone. And thyroid stimulating hormone is essential because it stimulates all the steps in the formation of the thyroid hormones. The anterior pituitary itself is under the control of the hypothalamus. And the hypothalamus secretes thyrotropin releasing hormone or thyrotropin releasing factor to stimulate the anterior pituitary to cause formation and release of thyroid stimulating hormone, which will activate the thyroid gland. Now, the thyroid hormones in the blood exert a negative feedback loop. If there are enough thyroid hormones in the blood, they will inhibit the hypothalamus to release TRH, and they will also inhibit the anterior pituitary to release TSH. And in this way, an equilibrium is maintained in the blood for thyroid hormones. The two thyroid hormones, the thyroxine or T4 and the T3, out of them the T3 is the active hormone that take part to exert the effects of the thyroid hormones. But mostly in the thyroid gland, the thyroxine is formed, so that 93% of the thyroid hormones will be T4 and only 7% will be T3. But at the level of the tissue, particularly in the liver, kidney and muscles, this T4 is converted into T3 by the enzymes deiodinases, the process called deiodination, by removing one iodine and converting T4 into T3. And thyroxine also has its effects, but the most active and powerful effector is the T3. It is 4 times more potent than thyroxine. And finally, the functions of the thyroid hormones are carried out by at the cellular level by the triiodothyronine. There are some important points that I want to mention, that in addition to the thyroid follicular cells, the thyroid gland also contain a different population of cells known as the parafollicular cells or C cells that have a separate embryological origin. And these parafollicular cells or C cells, they secrete another hormone known as the calcitonin, which is entirely different from thyroid hormones, and it has got its association with the calcium level in the blood. When there is hypercalcemia or excess calcium in the blood, the calcitonin is secreted, which will increase the deposition of calcium and phosphate in bones, and it will lower its blood levels. This calcitonin affects and acts totally opposite to the parathyroid hormone, which causes release of calcium and phosphate from the bones. But however, the role of calcitonin as compared to parathyroid hormone, it has got a very minor role. When T4 is converted into T3, this deiodination results in the formation of a third hormone which is known as the reverse T3. And the reverse T3 is physiologically an inactive hormone. However, certain conditions like starvation and diseases that occur outside the thyroid gland, known as the non-thyroidal illnesses, the reverse T3 concentration is increased, and clinically we measure it in non-thyroidal illnesses, and it may give us valuable information. We know that T4 is converted into its active form in the tissues, and there are certain drugs that will inhibit the synthesis of thyroid hormones by the thyroid gland, and these are of great importance in treating the diseases in which there is excess formation of the thyroid hormone, known as the hyperthyroidism. Both decreased formation of thyroid hormones, known as hypothyroidism, and excess formation of thyroid hormone, known as the hyperthyroidism, these both are the pathological forms of thyroid diseases, and they may have serious consequences and complications. So suppose if we are treating a patient of hyperthyroidism, we want to suppress the formation of thyroid hormones, and we use certain drugs like thionamides to inhibit the formation of thyroid hormone. So the thionamides inhibit thyroid hormone by its two effects. As we know that oxidation of the iodide to elemental iodine is important before it can unite with the tyrosine. So the thionamides, they inhibit the oxidation of the iodide to iodine, and in this way the thyroid hormone synthesis is inhibited. Also we know that monoiodotyrosine and diiodotyrosine will unite together, and they undergo coupling to form the T3, and the thionamides also inhibits this coupling of MIT and DIT to form T3, and these, by exerting these two effects, by inhibiting oxidation of iodide and inhibiting the coupling of the MIT and DIT, these drugs inhibit the formation of the thyroid hormones. When there are no thyroid hormones, the basal metabolic rate will go down below 50% of the normal, because the thyroid hormones, they are accelerating pedals for the metabolism. And in condition in which there is very low level of the thyroid hormone is known as the hypothyroidism. On the other hand, or on the other end of the extreme, if there is excess thyroid hormone synthesis, the condition is known as the hyperthyroidism. And in hyperthyroidism, the basal metabolic rate may become doubled. 100% increase, 100% of the normal increase. And this condition is hyperthyroidism, and it can lead even to lethal complications. Now, once the thyroid hormones are released by the follicular cells into the blood, they are carried in the blood bound to various proteins. The most important is the thyroid binding globulin, and Some thyroid hormones are also bound to albumin and pre-albumin. The protein bound form of the thyroid hormone is of no use. It just acts as a storage, and small amounts of thyroxine and T3 are released from these proteins. And this free portion, known as free T4 and free T3, they will do what the thyroid hormones are supposed to do. The protein bound thyroid hormones are physiologically inactive, and small amounts are gradually released from these proteins into the free T3 and free T4 forms. Now, the end of the thyroid hormones occurs when thyroid hormones are deiodinated in the body and metabolized in the tissues. And the other way is conjugation of the thyroid hormones in the liver and its excretion in the bile. And some hormones are excreted by the kidneys. So that is the end of the thyroid hormones. Now the mechanism of action of thyroid hormones on body tissue, we have discussed previously that some hormones have got their receptors in the cell membrane like peptide hormones, for example insulin, glucagon, anterior pituitary hormones. Some hormones have got their receptors in the cytoplasm of the cell like steroid hormones. But thyroid hormones have got their receptors in the nucleus of the cell, not in the cell membrane, not in the cytoplasm, but directly in the nucleus. And a region of the DNA which is known as the thyroid hormone response element. This region has the thyroid hormone receptors. And normally, the thyroid hormone receptor is bound to a co-repressor protein. And this co-repressor and receptor complex, it has inhibitory effects on the gene expressions. But once the thyroid hormone enters into the cell, most of the T4 is converted into its active form, the T3. And when T3 binds to its receptor, what happens that the co-repressor molecule detaches and another molecule known as the co-activator molecule, it binds to the TH receptor and T3 complex, and this will now activate the gene expression and will lead to the synthesis of structural and functional proteins, and these proteins, they will accelerate the basal metabolic rate. The thyroid hormones act on metabolism like we put fuel on fire. Thyroid hormones increases the metabolism and use of macronutrients like carbohydrates, fats, and proteins, and increases the heat production and energy production by the body. Thyroid hormones has got its role on the growth, particularly if we talk about the congenital hypothyroidism or newborn hypothyroidism. The absence of thyroid hormone in the newborn, if it is not treated on early basis by starting administration of synthetic thyroid hormones, the child will not grow in a condition known as the cretinism, in which the child remains a cretin. And for this reason, screening in the most of the European countries is active, and they check for the presence of thyroid hormones in the newborn by testing the thyroid stimulating hormone, which is a sensitive test for the uh, thyroid abnormalities. So thyroid hormones has got roles in the development of the central nervous system. It has got its effects on cardiovascular system and many other body systems. They are activated, and the metabolism in these organs and systems is accelerated. Thyroid hormones accelerate the basal metabolic rate, which will result in burning of energy from carbohydrates, fats, proteins, and it will lead to heat production. Coming to the fat mobilization, thyroid hormone stimulates lipolysis, and this will result in the breakdown of triglycerides into fatty acids and glycerol, and there will be increased concentration of fatty acids in the plasma, and they will be oxidized. The fatty acids will be oxidized for energy, and also the thyroid hormone decreases the concentration of cholesterol and triglycerides in the blood, and this is very important because patients of hypothyroidism suffer from hypercholesterolemia, and we know that elevated level of cholesterol is a risk factor for ischemic uh, heart diseases, peripheral vascular diseases, and other abnormalities. Thyroid hormones also accelerate the protein metabolism. It increases and accelerates the breakdown and synthesis of proteins. But if it is in its excess form, by that what we mean uh, in hyperthyroidism, then the breakdown of proteins will exceed the synthesis and will lead to severe muscle wasting and weakness of the person. The thyroid hormones also stimulate the sympathetic or autonomic nervous system, and it stimulates the response of the cardiovascular system and central nervous system to the catecholamines, adrenaline and noradrenaline. And by stimulation of the sympathetic nervous system, the thyroid hormones are responsible for the flight or fight response in associated with cortisol and adrenaline. Thyroid hormones stimulate the heart rate, respiratory rate, and cause the person to be alert. In combination with the growth hormone, the thyroid hormone stimulate the growth of the long bones, and particularly it is very important for the development of the brain. And if a newborn child which is deprived of the thyroid hormones will be cretin as well as mentally retarded person due to impaired development of the brain. Especially on carbohydrate metabolism, the thyroid hormones increase glucose absorption, gluconeogenesis formation of glucose from non-carbohydrate residues, and glycogenolysis in which glycogen is broken down into glucose. And in this way, the thyroid hormones make the availability of lot amount of glucose to be used for energy and to undergo glycolysis. In the cellular level, thyroid hormones increase the number of mitochondria. It stimulates the sodium potassium ATPase pump through the membranes, and it increases the oxygen consumption of the cells, which is essential for aerobic glycolysis. By increasing the concentration of glucose in the blood, which will stimulate insulin secretion by the pancreas, and the result will be increase in the metabolism, particularly the basal metabolic rate. Summarizing the effects, thyroid hormones are essential for growth, development, for the control of basal metabolic rate, and causing increased oxygen consumption in the target tissues, and by increasing the sensitivity of the target tissues, particularly cardiovascular and central nervous system, to catecholamines, and which will accelerate the breakdown of lipids, fats, breakdown of glycogen into glucose, and gluconeogenesis or formation of glucose from the non-carbohydrate components. Now, during abnormalities of the thyroid hormones and thyroid gland, we do certain tests. The total T3 and total T4 represents the protein bound thyroid hormones. As I mentioned, the thyroid hormones in the blood, they are mostly bound to thyroid binding globulin, albumin, and prealbumin. So we can measure the total T3 and total T4, but it is less valuable. And the small amounts of free T3 and free T4, which is the active form and which is the functional form of the thyroid hormones, their measurement is of great importance. And even more important is the measurement of the thyroid stimulating hormone. Thyroid stimulating hormone will be increased in hypothyroidism and it will be decreased in hyperthyroidism. The thyrotropin releasing hormone test is done basically to differentiate between the hypothalamic and pituitary disorders. If the TRH test stimulate the secretion of TSH from the pituitary, this means that the problem is in the hypothalamus. And if the thyrotropin releasing hormone fails to increase the release of TSH from the anterior pituitary, this means that the problem lies in the pituitary gland. We do ultrasound, which may give us valuable information. We know that iodine uptake occurs in the thyroid gland. It takes or uptakes iodine for the formation of the thyroid hormones. If we give radioactive iodine, it will be taken up by the follicular cells and we can take pictures through a camera and we can make an assessment of the presence of the hyperactive or underactive tissue in the thyroid gland. We will discuss this in detail later on. Because radioactive iodine also is very dangerous, because it is just like that we give some person poison in the food. Radioactive iodine in the thyroid gland will cause destruction of the follicular cells by inducing radiation. Various uh, thyroid scans, particularly the syncytium thyroid scans, are important for diagnosis or help in diagnosis of the thyroid disorders. Thyroid autoantibodies that are mostly seen in autoimmune diseases, for example, Hashimoto thyroiditis that cause the hypothyroidism and in which we search for the TPO or thyroid peroxidase antibodies, and at the other end, the Graves' disease, which causes hyperthyroidism and thyrotoxicosis, we search for the TSH stimulating antibodies. So, by summarizing the tests, we know the feedback loop for the synthesis of thyroid hormones. And the TSH is the first line test. The TSH, increased TSH means hypothyroidism. By this we mean that thyroid hormones are not properly produced, and the low level of thyroid hormones will stimulate the hypothalamus and anterior pituitary to increase the secretion of TSH. So it is the first line test in thyroid disorders, and it will be elevated in hypothyroidism and it will be decreased in hyperthyroidism, where the excess availability of the thyroid hormones will suppress hypothalamus and anterior pituitary to decrease the secretion of TSH. Second to this first line TSH level measurement are the measurements of free T3 and free T4, and they represent the non-bound hormones or active hormones. The protein-bound hormones represent the total level of T3 and T4, and since this measurement depends on the binding protein concentration, so it may give us less valuable information. As I said in the TRH stimulation test, that was an old test and now rarely used in the laboratories, we can differentiate between the hypothalamic and pituitary disorders. And particularly in hypothyroidism, if the administered TRH succeeds to stimulate the pituitary to cause the release of TSH, then the disorder will be in the hypothalamus, and if it fails to do so, the problem will be in the pituitary gland. The normal free level of T4 is 9 to 26 picomoles per liter, while that for the T3 is in 3 to 9 picomoles per liter. T3 measurement is very important for hyperthyroidism, and since most of the T4 is converted into T3 at the peripheral level, so a normal level and in the face of elevated T3 will indicate the T3 induced thyrotoxicosis. The normal level of the TSH is measured in milli international units per liter, and it should be 0.3 to 4. And for overt hypothyroidism, we take the concentration up to 10 milli international units per liter, and the range between 4.5 and 10 milli international units per liter is considered to be a state of subclinical hypothyroidism that we will discuss later on. If the first line test shows normal TSH, the patient is euthyroid, nor hypothyroid, neither hyperthyroid. It is normal. Increased concentration shows hypothyroidism. However, small increases in TSH may also occur in borderline cases, and particularly during recovery from other diseases which are non-thyroidal illnesses. In hyperthyroidism, TSH will be suppressed by the presence of excess thyroid hormone in the blood. However, in some conditions, low levels may also occur in subclinical diseases and non-thyroidal illnesses. The very important is the sick euthyroid syndrome that occurs because the problem is not in the thyroid gland but diseases that may affect the peripheral conversion of free T4 into T3, may affect the abnormal levels, and we will discuss euthyroidism next. Thank you very much.